Okay, so thank you for inviting me to talk. This brings back a conference, an FDA conference that I went to in 1985 that Bob Temple was running on trying to get people who were 65 and older into clinical trials and not have that be an exclusion. Considering my current age, I'm really glad we've made progress in the past 35 years. I'm going to start by talking about kind of the holy grail of drug trials, which are randomized controlled trials, just so we're all on the same page. And of course, the purpose, as you well know, of these trials is to determine the efficacy of the drug. Is this drug beneficial? And do the benefits outweigh the risks? That's the primary question. And because of that, the population in these trials is very homogeneous. And what you want are groups that differ only by study drug exposure. Totally makes sense in an efficacy trial, but it results in very restrictive inclusion and exclusion criteria and age criteria. And I know all these will be talked about later. If we find a statistically significant difference, that may be the end of trials, okay? There may be no further trials. Longer trials may not happen. There may be a replication depending on the size of the trial. And it leads to things like this. So this is an ad that came out when quetiapine first appeared. This has nothing to do with AstraZeneca. It has everything to do with the way drugs are utilized after they're approved in clinical trials. And if you take a look at this man is who they are trying to say might need this drug. Think about him. And then in the very small print, in pivotal clinical trials, 7% of patients were 65 years or older. Okay? Think about the numbers there, and that half of them got the drug. Very little, we know very, very little about the efficacy of this drug in these people, and yet we're being urged to prescribe. Just to remind you, and because I'm a geriatrician, I have to have the slide, the older population is increasing greatly. We're about here right now, okay? And you can see that really the 85 and older are taking off in numbers, and some say it's the 100 and older people. So I want to concentrate on the fact that if you've seen one old person, you've seen one old person. And as Dr. Appleby said, the heterogeneity of aging is significant. So these are three people who represent patients of mine. The first on the left is a 90-year-old woman. Her only problem is high systolic blood pressure. The person in the middle is actually 78, Letitia. She has COPD, she has diabetes, she has new rheumatoid arthritis, and she has low vision from the diabetes. And the person on the end is Nancy. And Nancy has mild, moving to moderate Alzheimer's disease and some lumbar stenosis. Who gets into the trials? Well, the oncologists have started to look at this in a nice way, and they're simple on it. They call people fit, vulnerable, or frail. And there are lots of different scales that we can talk about that put people into these different categories. But the bottom line is that the people who get into most studies are much closer to Ruth over here than to Letitia or Nancy. And yet, again, once the drug is FDA approved, these folks can get it. So question number one, can we extrapolate RCT results from young people to old? I spent a large portion of my career giving baby dose aspirin to people who did not have a history of cardiovascular disease as primary prevention until this trial came out in 2018. Aspirin and reducing events in the elderly, the Aspirin trial, and it's really in the healthy elderly, and they make no bones about that. almost 20,000 people, 19,000 people, all of them over 65, half of them over 74, community dwelling, over 70, unless they were in the US, Black or Hispanic, then people who were over 65 with the sense that they were at greater risk of cardiovascular disease and could have no chronic illnesses likely to limit survival during 5 years, no cardiovascular or cerebrovascular disease. The exclusions were dementia, high risk of bleeding, and substantial physical disabilities. And for those of you not familiar with ADLs and IADLs, these are substantial disabilities. The outcomes were excellent. Death, dementia, or persistent physical disability. So this is the composite outcome, and you don't need to be a statistician to look at this and say there's absolutely no difference, no benefit in taking aspirin or placebo to that composite endpoint. And when you look at the different pieces of the endpoint, there actually is an increase in death with aspirin. Doesn't seem to have much of an effect at all on dementia. And there's a tendency, a trend, toward a decrease in persistent physical disability. And that depends on how you define it, another topic. But the big finding that many of us in geriatrics had seen in other studies is the increase in major hemorrhage from aspirin. And so even in Ruth, who is a totally healthy 90-year-old, there would be no benefit and serious harm to following the recommendations that many have made to give her prophylactic aspirin. How about from fit to frail? If something works over here with Ruth, will it work over here with Nancy? For that, I'd suggest we look at the SPRINT trial as an exemplar of a way to look at this. And this tested systolic blood pressure, targeted systolic blood pressure for older adults, either less than 120 versus less than 140. 2,600 participants, 80 years old, a large primary outcome. Follow-up median was 3.4 years. And the results, to the shock of many of us, was that there were less fatal and non-fatal cardiovascular events and death from any cause with this low blood pressure. And so all the geriatricians said, what about the frail folks? Well, they looked at the frail folks. They used an index of frailty, and there are many different ways to measure frailty, but they found the frail patients, not surprisingly, were more likely to have these cardiovascular events. But if they were treated to a blood pressure of less than 120, there was a lower absolute event rate. If they stratified by gait speed instead of frailty, they found the same results. This was in a secondary analysis, but they found no benefit in those who had cognitive impairment, low MoCA scores. So it appears that what you use as an index for frailty or functional impairment or cognitive impairment matters. So how can you determine efficacy in heterogeneous older adults? You want to measure and analyze this by the constructs that may affect the outcome, and that includes the adverse effects. So here are our 4 friends. And why is this not happening? It's not clear which construct or tool to use. You may need to use more tool, and you may need direct observation, which costs a lot of money. The other thing that we really need to look at are outcomes that matter for older adults in our trials. So for some of my patients, life versus death, not so much. It's how they live. And that's our same 4 as we've been talking about. But you see in the literature oftentimes important outcomes that aren't reproducible. So you see people measuring disability. Disability is a social and environmental construct. It does not, something isn't disabling if you can access or afford assistive devices or remodeling. You have the impairment, but you don't move to disability. Nursing home placement depends on the number of nursing home beds, depends on whether you have resources to be able to age in place, and resources like 24/7 assistance, financial, being able to retrofit your residence. So in summary, what are the issues here? We need greater numbers of older people who have more heterogeneity, frailty, cognitive impairment, functional impairment, multimorbidity, and history of falls. We need to analyze outcomes for these groups. We need to use outcomes that are meaningful to patients and reproducible. The gaps, which constructs and tools to use to capture the heterogeneity? And does this depend on the disease and or the treatment being tested? And for that, I would refer you to a wonderful editorial by the next speaker, Dr. Kutchell. Thank you.